Hello and thank you for coming. So welcome back to another session of NeuronUP Academy. For those of you who have attended before, thank you for continuing to support us in this 4th edition of the English Language NeuronUP Academy. To those of you with us for the first time, I want to give you a very warm welcome to NeuronUP Academy, which is the monthly series of presentations we've created with the idea of sharing knowledge among professionals and students working in cognitive sciences and cognitive health. We have a very international audience with us, and I'm happy you could all be here with us today. My name is Brian. I work here at NeuronUP. NeuronUP is the leading cognitive stimulation platform for professionals. Today we are honored to present Dr. Stephanie Kolakowsky-Hayner, I hope I'm saying that correctly, who will be giving her presentation entitled Concussion 101, an Introduction to Mild Brain Injury. Before introducing our guest and getting on with the presentation, I would first like to share a short video about NeuronUP so that all of you who still aren't familiar with our neurorehabilitation platform can get an idea of what we do. Give me 1 second.
Do these work situations sound familiar? Hours surfing the internet and struggling with your computer? Tons of material to sift through and organize, yet finding the same activities over and over. Doubts about which materials to use for follow-up? Do you imagine personalizing exercises so they are just right for each individual? Would you like a simpler way to monitor progress, count on the assistance of other professionals, share ideas, and stay up to date? NeuronUP, a web platform for professionals dedicated to neurorehabilitation and cognitive stimulation. Acquired brain damage, neurodegenerative diseases, normal aging, neurodevelopmental disorders, and mental illness. Numerous materials and innovative tools, classified into over 40 cognitive processes, cataloged by difficulty, age, and mode, with a multi-format application. The treatments are adapted to each person, which favors generalization and adds greater ecological validity. NeuronUP is accessible anywhere, allowing for greater proximity to patient and the ability to design sessions so that each user can work anytime, anywhere. With NeuronUP, you can communicate with other professionals and stay current. The future of neurorehabilitation is at your fingertips.
All right, very good. So again, thank you for joining us here today and supporting NeuronUP Academy. If you would like to learn more about our platform for professionals, don't hesitate to visit our webpage. You can sign up for a free webinar, request a free trial, or ask any questions you might have. We have an easy chat feature on the website to use. We've just released some exciting updates to the platform. It's much more visual, much more user-friendly. I'd be happy to help you guys with any questions you have. You can shoot me an email directly at Brian, B-R-I-A-N, @neuronup.com. So on to our speaker. I'm going to read a bit of Dr. Kolakowsky-Hayner's bio for those of you who don't know her yet. She is the Associate Professor of Research in the Department of Rehabilitation and Human Performance at the Icahn School of Medicine at Mount Sinai in New York. Dr. Kolakowsky-Hayner serves as the Director of Spinal Cord Injury Research. She's a Senior Investigator at the Brain Injury Research Center and the Director of Rehabilitation and Research Education. She serves on local, state, regional, national, and international boards and contributes to the development of new research protocols, dissemination of activities, outreach, and awareness efforts to improve the lives of individuals with disabilities and the people who care professionally and personally for them. Dr. Kolakowsky-Hayner has over 20 years of progressively independent experience in research related to spinal cord injury, brain injury, stroke, and other neurological disorders. To date, she has made over 200 professional presentations and published over 220 peer-reviewed manuscripts, book chapters, and other informative materials for professionals and consumers with disabilities. I want to welcome and thank Dr. Kolakowsky-Hayner for taking time out of her day and putting together this presentation to share with us. And one last thing before we start, I want to mention that today's presentation will be in 2 parts. First, Dr. Kolakowsky-Hayner will give her presentation, which will last about 50 to 55 minutes. And in the last 10, 15 minutes or so, we'll open up the floor for those of you in attendance to ask questions in the chat feature. As to not distract from the presentation, it would be appreciated if you could hold off on your questions until the end of the presentation in the allotted time given for them. At the end, if we have a ton of questions and we don't get to them all, I'll compile those and send them on over to be answered by Dr. Kolakowsky-Hayner, and we'll post them on the blog, as well as we'll post a video on the blog for those who want to revisit or who missed out on the presentation. So thank you again for joining us, and I'll turn the conversation over to Dr. Kolakowsky-Hayner. It's all you. Thank you much.
Let's get those slides up. As Brian said, hi, I'm Stephanie. That's a really long last name that we don't need to keep repeating. Today we are going to talk a little bit about concussion and mild traumatic brain injury. And without further ado, I will get that started for you. First off, I would like, let's move these slides ahead. All right, Brian, there we go. And done. Sorry, getting used to the software. So first, I would just like to define what brain injury is. There are a variety of different definitions depending on where you're looking. There's acquired versus traumatic, primary versus secondary injury, and open versus closed head injury. And what an acquired brain injury is an injury to the brain that is not hereditary, congenital, degenerative, or induced by a birth trauma. It occurs after birth and is presumed a interruption to normal brain development. It results in a change in neurological activity. The physical integrity of the brain may be affected. The metabolic activity of the brain may be affected, and it also may affect functionality at the nerve cell as well. Acquired brain injury is basically an umbrella definition that includes injuries caused by external physical forces to the head, as well as internal insults to the brain, such as an aneurysm or a stroke. Non-traumatic brain injuries include stroke, neurotoxic poisoning, hypoxia and anoxia type injuries, among a number of different etiologies. And hypoxia and anoxia include basically a lack of oxygen to the brain, which causes the brain cells to die. And when they die, they release chemicals that could cause additional brain damage within the brain itself. It releases a neurochemical cascade, if you will, of additional damages. A traumatic brain injury, on the other hand, is an alteration in brain function that's evident, or other evidence of a brain pathology caused by an external force to the head. With a traumatic impact, the head is struck by an object or it strikes against an object, and it results in either a closed head injury or an open head injury. The primary injury, or the initial injury to the brain, is what defines the injury as traumatic versus non-traumatic. And this information basically helps determine the severity of the injury. It informs different surveillance data, such as data that's collected by the Centers for Disease Control or other epidemiologic agencies. It correlates to long-term outcomes in individuals with brain injury. And the mechanism of the injury is mechanical. So basically, for example, the neurons are damaged from a penetrating injury or from a stroke, and that's considered a traumatic brain injury. The primary injury itself causes a cascade of adverse events that lead to secondary brain injuries. And it could be, as I said, a neurochemical cascade similar to an acquired brain injury. It could be the release of excitatory amino acids, it could be oxidative free radical responses or disruption in your neurotransmitters that could possibly impact the brain overall and cause secondary injuries, which include hypoxia, anemia, metabolic abnormalities, hydrocephalus, intracranial hypertension, different types of hemorrhagic activity. And basically, these are all things that can occur after the initial brain injury, typically during acute hospitalization or rehabilitation. And then the difference between an open and a closed head injury is pretty simple. An open head injury is basically when there's some sort of penetrating brain injury. It's a breach in the skull or a breach in the meninges, so that the object penetrates the skull and actually enters the brain. And this type of injury often results in more of a focal type of an injury, very focused insult to the brain. And infections are often common after an open head injury, and that could be a significant factor in recovery. Closed head injuries are basically non-penetrating brain injuries, and they typically cause what's called the diffuse axonal injury, and we'll talk about that in a few minutes. But the most common types of brain injury include a contusion. And basically what a contusion is simply put, is a bruise to the brain. Hang on one sec. Sorry. And it's basically bleeding on the surface of the brain, and it's due to a localized trauma. And it most commonly occurs in the frontal or the temporal regions of the brain. And it's usually caused by the brain actually hitting bony structures within your skull. And the contusions can either occur alone or with some more severe hematomas, which we'll talk about also. Contusions usually occur with moderate to severe brain injuries and often result in brain bleeding and brain swelling within the first 48 to 72 hours, and often require a craniotomy or removal of a skull flap. And they're most rapidly and accurately diagnosed with either a CT scan or an MRI scan. Still getting used to these slides. So as I said, there's a variety of different types of hematomas that can occur. It's basically a collection. I'm not sure if my pointer's coming up or not. Hang on. Pointer. Yep, there we go. It's a collection of blood within the skull. There's a variety of different kinds, as I said. It's most commonly caused by the rupture of a blood vessel within the brain due to some type of a trauma. The blood collection can be within the brain tissue here, which is an intracranial hematoma. It can occur underneath the skull and causes pressure on the brain, such as an epidural or a subdural hematoma. The epidural hematoma occurs about half as often as a subdural hematoma, and that's when blood accumulates between the skull and the dura mater, and which is the thick membrane that covers the whole brain. The subdural hematoma, on the other hand, is the most common type of traumatic intracranial bleeding. And that occurs when the blood collects on your brain surface beneath the skull. It's a collection of blood below the inner layer of the dura, but it's external to the brain and the arachnoid membrane itself. And an intracranial hematoma, as I said earlier, is where the blood actually accumulates within the brain itself. Cannot get these slides to go. Here we go. As I said earlier, a lot of closed head injury, or all closed head injuries, basically induce what's called diffuse axonal injury, and this is extremely common in concussion. Diffuse axonal injury, or DAI, occurs in about 50% of severe brain injuries. It's also present in moderate and mild injuries, and it's associated with basically traumatic acceleration and deceleration, or rotational type injuries where the brain moves within the skull. It's extremely common after automobile accidents, sports-related accidents, violence, falls. It's extremely common in shaken baby syndrome and child abuse. And diffuse axonal injury consists of basically a focal lesion or tearing of the axons. And the shearing and the lesions are labeled as diffuse because instead of occurring in a specific focal area of the brain, it occurs throughout a variety of the different brain structures simultaneously. It's not only the most common type of brain injury that there is, it also happens to be the most deadly. Diffuse axonal injury is not caused by just a simple blow to the head or a penetrating type injury. It's caused by the movement of the brain within the skull. And the most common type of diffuse axonal injury is the coup-contra-coup type of an injury, where the head's impacted on one side, the brain receives an injury directly where that focal injury is. However, the brain then moves within the skull and causes a subsequent injury to the opposite side of the brain. It's caused basically with a linear type of an injury where it strikes back and forth within the skull itself. So it's rapid acceleration and then rapid deceleration, resulting in what we would call the coup and then the contra-coup injury. So the direct injury and the indirect injury, basically on the opposite side of the brain. So a little bit more about the specifics of brain injury. It's estimated that approximately 2.5 million people sustain a traumatic brain injury every year here in the United States, and that about 2 million people happen to be treated and then released from the hospital or an emergency department, and a significant portion of those folks are mild traumatic brain injuries, or what we call concussions. It makes up approximately 75% of all the injuries that are seen and released at a hospital, if they're even treated at the hospital. Basically, the individuals are seen in the emergency department and then let go and released to their homes. Only approximately 3% of all of these types of injuries result in death or are significant and severe enough to result in death. So as you can see, concussion is a pretty big epidemic or public health issue. And that's just the people that are actually seen in the hospital. It's important to remember that the incidence is the number of times that these injuries are occurring, but the prevalence is how common the injury is within a specific population. And unfortunately, a lot of people aren't even reporting concussions or mild traumatic brain injuries, or even going into an emergency department to be diagnosed and then released until symptoms start to appear later on. And we'll talk about that a little bit more in detail. The brain injury itself is the most prevalent disability here in the United States. It's estimated that approximately 13.5 million Americans, or 4.5% of our entire population, are currently living with a brain injury. So they've had a clear diagnosis and been released and are home trying to live their lives after they've received an insult to the brain. Regarding the different mechanisms of injury, as we talked about a little bit earlier, it's extremely common after a fall. The incidence and prevalence of brain injury and the different mechanisms of injury vary by age. We see that a large number of individuals who are 0 to 4 years old, I believe, are injured due to violence and falls. And then we see a very similar pattern in the elderly. People that are 65 and older are more likely to be injured as the result of falls. Falls are actually now in the United States the number one cause of traumatic brain injury. It used to be motor vehicle accidents, and we were seeing a large portion of the population, 25 to 65 basically, was our key demographic for traumatic brain injury, and it was more common in males than females. However, with the aging population increasing, we are seeing the numbers of people that are injured as a result of falls really increasing throughout our population. So our average age of injury is also going up. A lot of the times, with regard to mechanism, non-traumatic brain injuries, the most common, obviously, is stroke. It's either caused by a hemorrhage or a blood clot. We see different types of brain injury due to infectious disease, such as encephalitis or meningitis. We also may see a seizure disorder, electric shock, or a lightning strike, which is not exactly common. We see different types of brain injury due to tumors, which also may have secondary injuries due to the surgery removing the tumors, or the radiation, or the chemotherapy that people are incurring as a result of these tumors. Different types of toxic exposure also cause acquired brain injuries, such as, and that includes substance misuse. If someone is injured due to lead poisoning, that's more common in children than adults. If they're inhaling or huffing different types of volatile agents, that we see a big rise in the incidence in teenagers who are trying different types of inhaled substances. We also see acquired brain injury occurring due to metabolic disorders, such as insulin shock in individuals with diabetes or a diabetic coma. Liver and kidney disease also has secondary consequences, resulting in brain injury, acquired brain injury as well. You may see neurotoxic poisoning, such as carbon monoxide poisoning, which is also often results in one of those, in the 3% of the death cases that are seen due to neurotoxic poisoning. It could also include inhalants. There's a lot of workers' comp cases that have to do with different types of neurotoxic poisoning. And then also another mechanism for acquired brain injury, as we talked about a little bit earlier, is anoxic and hypoxic type brain injury, where there's a lack of oxygen to the brain, causing brain damage. And that can happen due to cardiac arrest, different types of pulmonary diseases, strangulation we see as a result of domestic violence. When people are near drowning, we see a lot of hypoxic type injuries. The number one mechanism, as I did say, currently is falls, and it's due to the large aging population. With regard to outcomes, persons with brain injury have a reduced life expectancy of approximately 7 years compared to their peers in the community without traumatic brain injury, they're more at an increased risk of seizures and other comorbid conditions due to their brain injury. And that could include different types of aspiration pneumonia. That's actually the most common study done by Harris and Felix and colleagues out of the Traumatic Brain Injury Model Systems of Care that are funded through the National Institutes on Disability, Independent Living, and Rehabilitation Research here in the United States, found that aspiration pneumonia occurred 49 times more often in individuals with traumatic brain injury than in their peers who did not have traumatic brain injury history. They were also 22 times more likely to incur seizure disorders, 12 times more likely to incur septicemia, and 29 times more likely to have circulatory problems after their brain injury than their peers who have not incurred a traumatic brain injury. It's really not clear if the chronic damage is due to the traumatic brain injury or the traumatic insult itself, or it's just some sort of progressive injury or illness that these individuals might have been susceptible to before the brain injury. But basically, the TBI and the neurochemical cascade does cause additional comorbid conditions, and it's more likely to occur in an individual with a brain injury than someone who hasn't had a brain or a history of brain injury in the past. So with regard to the different types of severity of traumatic brain injury, it's typically characterized into 3 levels of severity, which include mild, moderate, and severe. And as our talk today focuses a little bit more on the mild traumatic brain injury, they can have early either a brief or absolutely no loss of consciousness whatsoever. Individuals with a mild traumatic brain injury may or may not experience post-traumatic amnesia. Symptoms of a mild traumatic brain injury include dizziness, vomiting, confusion, lethargy. Their Glasgow coma score would be in the range of a 13 to a 15, which is the maximum score you can get on a Glasgow coma score. And oftentimes with a mild traumatic brain injury, the imaging that is done, if any imaging is done at all, comes back and it looks pretty normal. With regard to a moderate traumatic brain injury, a Glasgow coma score of 9 to 12 is the range for that type of an injury. It's often diagnosed by a loss of consciousness for any period of time that includes 15 minutes to 6 hours under some definitions, 24 hours under other definitions, a period of post-traumatic amnesia between 1 and 24 hours. Some scales look at it between 1 and 7 days, and a moderate injury often includes a skull fracture with a contusion or some type of a bleed, hemorrhage within the brain. It also may show up clearer on a CT scan, or different types of findings on EEGs are more likely after a moderate brain injury. And then with regard to the severe injuries, this is the lowest end of the Glasgow coma score. It's basically anyone that incurs a Glasgow coma score of 8 or below. And it's often characterized by a loss of consciousness greater than 6 hours on some scales, greater than 24 hours on other scales. And then also PTA, or post-traumatic amnesia, that on some scales is greater than 24 hours and some scales is more than 7 days. And often you will have significant neurological findings on imaging, EEG. It's not going to take a 7T MRI to find effects of a severe traumatic brain injury. They're pretty significant on the lower end of the imaging scales. Today, as I said, we're going to focus more on the mild TBI and specifically concussion. And there, again, are a variety of different definitions out there for concussion, but the one I'm going to be discussing today is basically it's a mild traumatic brain injury with an alteration in mental status, which could be dazed, disoriented, confused. It may or may not involve a loss of consciousness, and that's something that is extremely important. A lot of people will say, oh, well, you didn't pass out, you didn't have a concussion, but that's not true. Concussions occur all the time without a loss of consciousness. It can result in the loss of memory for events immediately before the concussion or immediately after the concussion. And it can also result in focal neurologic deficits or local neurologic deficits, and often occurs, and diffuse axonal injury often occurs as a result of concussion, and it's very difficult to detect on neuroimaging, especially a CT scan. It's not strong enough to pick something up like that. Most concussions are not identified and they're not detected or treated, and therefore we see a lot of concussions that go undiagnosed or underdiagnosed. So we really don't know specifically what the incidence and the prevalence of concussion are, but we do know that it's a significant public health issue. As we start to review the mild traumatic brain injury or concussion, I want you to remember that a lot of the definitions of mild traumatic brain injury or concussions are based on symptoms that are ascribed to a mild TBI, and they may be due to non-brain injury phenomenon such as PTSD. And you really want to, if you're treating individuals with mild traumatic brain injury or trying to detect, you want to be have an increased attention to these type of factors. Again, I just want to reiterate that a concussion is a mild TBI and should be treated as a traumatic brain injury. The term concussion is actually a commotion of the brain, and it was derived back in the 16th century by Hippocrates, and back in as far back as 1839, the physiological impact of mild traumatic brain injury had been described in different medical texts. It has become extremely popular with the media and the general public since 1990. A lot of studies have come to focus more on concussion and mild traumatic brain injury. It was brought to the forefront due to the awareness of sports-related concussions within the National Football League here in the United States, and the controversies that surround that. All of the states here in the United States started passing concussion laws for youth sports, and then also back in the 90s, all of the conflicts here in the United States with Operation Enduring Freedom and Operation Iraqi Freedom, and then Operation New Dawn. We saw a huge insurgence of individuals within the military who were occurring mild traumatic brain injuries, and that really focused a lot of attention on mild traumatic brain injury, and a lot of the research funding and focus was to see if we can help those individuals coming back to the States after they served and were experiencing severe symptoms due to their mild traumatic brain injuries. The biggest part of the problem with mild traumatic brain injury nowadays is that there is no clear definition of concussion. It's not or there's not a common definition. There are a multitude of different definitions. So it's very difficult to compare apples to apples or concussion to concussion and study to study, because guidelines are not in agreement. Identification, diagnosis, treatment, there's still a lot of gray area out there with regard to specific definitions of concussion. Excuse me. The most commonly used definition of concussion is the one that was developed by the American Congress of Rehabilitation Medicine in 1993, and that states that a patient with a mild traumatic brain injury is a person who has had a traumatically induced physiological disruption to their brain function. It's manifested as one of the following: any period of a loss of consciousness, any loss of memory for events prior, immediately before, and immediately after the accident or the hit to the head, any alteration in mental state at the time of the, they say accident, but at the time of the insult to the brain. It could be if a person is feeling dazed, confused, disoriented, and any focal neurologic deficits that may or may not be transient. So they can exist for a period of time after the insult to the head, or they may dissipate pretty quickly. Basically, under the ACRM, the American Congress of Rehabilitation Medicine definition, an individual, the period of consciousness has less than 30 minutes long, and then after minutes, the initial Glasgow coma score of 13 to 15 would need to be scored, and then also they determine that the length of PTA or post-traumatic amnesia has to be less than 24 hours as well. Since 1993 and ACRM's definition of mild traumatic brain injury, there have been a number of others who have tried to define or come up with a clear definition of mild traumatic brain injury and concussion. And the latest consensus statement came out in 2017 from the International Conference on Concussion in Sports that was held in Berlin in October of 2016. And that panel in Berlin modified the previous definition that says sports-related concussions are a traumatic injury induced by biomechanical forces. They have several common features that may be utilized in clinically defining the nature of the concussive head injury, including sports-related concussion can be caused by a direct blow to the head, face, or neck, or elsewhere on the body with an impulsive force transmitted to the head. So if someone falls and there's a rotational injury, or, just the force of the fall itself could cause the brain to move with inside the skull and cause coup contra coup injury, or again with the frontal and temporal lobes commonly hitting some bony prominence within the skull. That's considered also a sports-related concussion. It typically results in the rapid onset of short-lived impairments, and that affects neurological functioning, and those short-lived impairments are seen to resolve spontaneously. However, the signs and symptoms could evolve over a number of minutes to hours, and may result in neuropathological changes. The acute signs and symptoms basically reflect functional difficulties rather than structural injuries, and the Berlin conference says there's no abnormality that is seen on standard structural or neuroimaging studies. And then also they said that their sports-related concussions result in a variety of different clinical symptoms and may not involve the loss of consciousness, as we saw in the other definitions of traumatic brain injury of the mild variety, and that resolution of both the clinical and the cognitive functions seem to come in a sequential course, but some symptoms may be more prolonged than others. And the clinical signs and symptoms can't be explained by drug use, alcohol use, medication use, or other injuries that may occur, such as a cervical injury, a peripheral vestibular type of an injury, or other comorbidities such as psychological problems or coexisting medical problems. And there is clearly still a lot of work that needs to be done with regard to these definitions, because they seem to be, while everyone seems to be having similar definitions, we're still not able to have one simple definition for concussion and mild traumatic brain injury that allows us to speak across multiple studies and compare data and really get a good handle on what this injury looks like and what the incidence and the prevalence are for mild traumatic brain injury overall. With regard to the mechanisms, it's basically similar to the general brain injury mechanisms, and the primary cause of mild traumatic brain injury or concussion includes the acceleration, deceleration type of an injury, striking your head against a hard surface, blasts, explosions, or being hit in the head. For example, personal case, my daughters both play water polo, and unfortunately the younger one, who was a freshman last year, got railed in the head with a water polo ball and couldn't figure out what she was doing after the game, and clearly had a concussion by being struck in the head, just by being hit in the head with a ball. So they could occur from acceleration, deceleration injuries with coup contra coup occurring within the brain. It could be hitting your head against something, common in diving accidents, common in bike accidents if someone falls off a bicycle or a horse and hits their head on the floor, and even in sports related concussion, tackling and the head hits the floor, or in soccer if people accidentally go up to head the ball together and hit their heads together. That's often a common mild traumatic brain injury or concussion mechanism as well. So, as the Berlin conference said, most of the symptoms of mild traumatic brain injury or concussion typically resolve early on after the concussion, but some symptoms last, 2 to 4 weeks in general or more. And the physical symptoms of concussion could include headaches, nausea, loss of balance, disturbed sleep, increased fatigue, which are two of the most common things that occur after a traumatic brain injury, especially a mild traumatic brain injury. We see a lot of individuals with sleep difficulties, both initiating sleep and staying asleep. Different issues with vision difficulties, sensitivity to light, sensitivity to noise, impaired hearing can occur as a result of a concussion, dizziness, other neurological abnormalities such as seizures could occur. And then another physical symptom of concussion could be numbness. Different cognitive symptoms also include impaired judgment, significant deficits to attention concentration, lack of memory for events that occur immediately before the concussion or immediately after the concussion. You don't see a long-term post-traumatic amnesia or pre-traumatic amnesia, but you do see some instances of individuals forgetting immediate events prior to and after a concussion. Sometimes there's difficulty forming new memories or retrieving other older memories. There's difficulty with learning that may occur, which is why we see a lot of not just return to sports anymore, but we're seeing a lot of return to school programs for individuals with concussion that are starting to be developed and are being developed similar to the NeuronUP cognitive rehabilitation programs, we're seeing a lot of that for school-age children who are returning after a concussion to school and need additional assistance, additional time in classes, additional time to take tests and things like that. We see a lot of difficulty with processing speed early on after a concussion. And then sometimes we even see some difficulties with executive functioning. A lot of individuals who have had a concussion experience different problems with anger management and different types of social situations that just become too overwhelming while they're recovering from their mild traumatic brain injury, which then also leads into the emotional difficulties after a traumatic brain injury of the mild type or a concussion, which could include anxiety. Depression is extremely common after a concussion. Oftentimes, people that don't even know they've had a concussion will experience the fatigue and the depression, and that's actually what leads them back to the diagnosis of a mild traumatic brain injury at some point. Is they're often really debilitated with the depression and the fatigue and go to be treated for that and realize that over a period of time they had a concussion that they were not aware of. And then lastly, the different behavioral type symptoms include, as I said, agitation, irritability, aggression, impulsivity, and typically 10 to 15% of people that have had a concussion experience persistent symptoms in the long term after their concussion. So it's not something that, as the Berlin conference suggested, it occurs for a limited time and dissipates quickly. We do see 10 to 15% of these individuals who have long, persistent symptoms. Specifically, the most common are the depression and the fatigue occurring after the brain injury. We're seeing a lot more research coming out showing that there are differences between men and women with regard to how they are recovering after a concussion. For example, women tend to report concussions more often than men. They're more likely to report more significant symptoms than men, and their symptoms seem to persist a lot longer than men's. And there's some speculation into the warrior status and the machismo behind men underreporting, but typically women are more likely to report. They're likely to report more symptoms and more severe symptoms that last longer than men's symptoms. The theory is that also women's necks are not as strong as men's necks. So we see a lot more of those acceleration, deceleration injuries in women. And it also allows for more rotational types of injuries where the brain is moving within the skull and causing frontal and temporal injuries due to the bony prominences again within the skull. A lot of research on brain injury is done in men because men are more likely to incur a traumatic brain injury than women. It basically, up until recently, most of the literature did not look at gender-specific outcomes, but a recent shift due to organizations like Pink Concussions, the American Congress of Rehabilitation, Women's Special Task Force, and other individuals throughout academia worldwide have really been focusing on looking at the implications of gender and sex on the different type of treatments, the severity, and specifically looking at differences between men and women with regard to mild traumatic brain injuries. There's a lot more literature out there right now looking at gender differences. So What do we do to assess and treat different types of mild traumatic brain injury? Basically, you could do different neuropsychological evaluations. They're absolutely invaluable in determining symptom causation. They should be considered absolutely necessary if someone is dealing with post-concussive syndrome, which we'll talk about a little bit more. Neuropsychologists basically can provide early interventions. They can recommend different types of therapy. They can build on strengths that the individual already or has preserved and try to ameliorate the weaknesses that are occurring due to the mild traumatic brain injury. They can monitor return to work, return to school, return to play, and then they can also treat the emotional difficulties with regard to any of the recovery problems that are existing, and can appropriately refer for sleep and other types of difficulties that may be occurring as well. And as with all traumatic brain injury, it is extremely important to time the treatment appropriately. The earlier the intervention, the better the outcomes. So just a little bit of research I want to share with you guys, and then we will open up to questions. This is a study that my colleagues and I had done out of Stanford, and we went through 1,096 studies and took a look at the differences with regard to post-concussion syndrome after mild traumatic brain injury. And we showed a statistically significant decrease in post-concussive symptoms and post-concussive syndrome after individuals were engaged in physical exercise compared to a control group of individuals, or compared to control groups of individuals who did not exercise after a concussion. Physical exercise also produced significant decreases in the PCSS score, which is the post-concussive symptom survey. And it also, we looked at different randomized control trials and saw that a subgroup of meta-analyses that we did, we found a reduction in symptomatology for individuals that were engaging in exercise after concussion. And we saw that adolescents and adults with concussions were reporting less symptoms fewer days after the concussion based on whether or not they were engaged in exercise after the injury. Hang on, slide. Here we go. This further shows that we see statistically significant, which is what these black diamonds are, decreases in post-concussive scores after individuals are engaged in physical exercise compared to the control group of patients with concussion who are not engaging in exercise. And we're not just seeing this in local studies, but this is common across all of the different studies that we looked at. And of the over 1,000 articles that we screened, we were able to pull out 14 specific studies, which included 5 randomized controlled trials, a propensity matching study, and then 3 cohort studies, and then 5 pre-post studies as well. And all of them are showing pretty significant differences in individuals who are engaging in exercise after their injuries. One more on this one, I believe. Yes. So some improvements were also seen with regard to impact scores, which is a common computerized assessment that's used after concussion. It's a measure that investigates the different neuropsychological impairments, as well as some physical and functioning impairments. And we saw that, again, within this group, the light and moderate intensity workouts were, we were seeing much improved scores on their impact scores. However, on the flip side, people that were engaged in very high intensity type workouts, we were seeing a decrease in memory scores. So a little bit of exercise is good. Too much is too much. So there's a lot of work that still needs to be done with regard to exercise, but we are seeing the absolute antithesis of what used to be prescribed as the normal treatment after a concussion, where go in a dark room, don't engage, no computer, no TV, no anything, and wake them up after every 2 hours kind of thing. We're seeing that actually increases depression. It increases anxiety. It's increasing a lot of the symptomatology and making the symptoms that are reported a lot worse and last a lot longer. So now it's get the individual engaged in an aerobic activity, let them sleep to help ameliorate the fatigue, if they are able to sleep and they're not having engagement issues to get to sleep or to stay asleep after their concussion. So we are seeing a complete 180 with regard to concussion treatment based on a lot of these studies that are out there now, which is great. Lastly, again, this is a similar meta-analysis that we had done and saw significant differences, again, with regard to activity versus rest for individuals after a concussion. And we're seeing those with activity are doing significantly better than those who are prescribed rest. McKeever and Schatz did this study looking at a variety of different, they did a meta-analysis also looking at post-concussion assessment schedules. And basically they found that there's little to no agreement in the schedule of serial testing to evaluate the different symptoms or the resolution of symptoms after a concussion, that there's no conformity to the different types of neuropsychological procedures that are used. There's no clear gold standard of assessment, treatment, length, time, measures, any of the above. And they suggested that serious study needs to go into really coming up with a gold standard clinical practice guideline for individuals after mild traumatic brain injury, because it's clearly lacking. As I mentioned before, post-concussive syndrome is not very common after mild traumatic brain injury. It occurs in 10 to 15% of the individuals who incur a mild traumatic brain injury. Their persistent symptoms typically last weeks or months after their mild traumatic brain injury. Typically, it's still debated what causes post-traumatic or post-concussion syndrome, or PCS. It includes things like poor early intervention, delay in seeking medical attention or seeking an intervention, allowing other factors to influence the behavior, increased risk factors, which include like substance use or alcohol use after a mild traumatic brain injury to help self-medicate. Oftentimes people will start drinking or taking drugs, and that impacts their ability to recover after a mild traumatic brain injury as well. Other risk factors for post-concussive syndrome incur ongoing headaches, persistent dizziness, persistent nausea, increased post-traumatic amnesia over an hour, If you are female, if you are over age 40, you're more likely than males and individuals under age 40 to incur post-concussive syndrome. If you've had a history of substance abuse in the past, you're more likely to have post-concussion syndrome or lingering effects of a mild traumatic brain injury. We see individuals with lower socioeconomic status often reporting higher levels of post-concussion syndrome. And whether or not the mild traumatic brain injury was a result of a traumatic event such as child abuse or domestic partner violence, those oftentimes result in post-concussion syndrome and a lack of resolution of symptoms as well. We really want to get to, as I said earlier, and as research has shown, we want to get to an early diagnosis. It should be multidisciplinary. It should be based on, it should be symptom focused, and it should be with the goals of providing compensatory strategies and restoring function. And some of the best folks to do that, as I said, are neuropsychologists and multidisciplinary teams of rehabilitation providers. Some of the complications that we see with regard to post-concussive syndrome is somatization and secondary gain. And I'll talk about that a little bit more in the next slide. There was a great study that Silver did looking at malingering and different reasons why we may see more post-concussive syndrome in some individuals than others. And then other complications that we see could include second impact syndrome, where someone has a second or even a third concussion before their first concussion has healed, which often leads to more severe type of an injury. It's rare, but it is a possible fatal condition. If you are injured a second time prior to your first mild traumatic brain injury healing, it could actually exacerbate the symptoms and the severity of the injury as well. Another up-and-coming area of research is chronic traumatic encephalopathy, and it's a rare but progressive degenerative disorder that has been shown to be associated with diffuse axonal injury, and it causes different types of problems with chemicals in your brain, such as tau, and that can in turn cause chronic inflammation. Researchers are working on a way to be able to identify chronic traumatic encephalopathy in living individuals. However, that has not been done yet. It's currently only discovered upon autopsy after someone has died after an injury. And last but not least, as I said, Silver did this awesome study looking at the different contributions to symptoms after concussion, and he found that this here is a model for understanding the different interactions, and he found that people may not be exaggerating or malingering after a concussion. After the initial effect, people often don't take into account normal psychiatric symptoms or other common psychological mechanisms such as stress, stereotypes, threats, anger, revenge, loss of fear of loss of self, and other types of symptoms that are normal that may be influencing individuals' symptomatology after their concussion. Different interventions that minimize the symptoms of concussion include optimizing the patient's expectations, treating their depression, anxiety, or post-traumatic stress disorder, minimizing the stereotype threats, addressing the feelings of anger, the loss aversion, and cheating, and then also considering the effect that any sort of secondary gain or money may have on the individual's behavior after the traumatic brain injury, but that individuals may not be malingering or exaggerating their symptoms. They just might have real, honest to goodness psychological issues that are going on after their mild traumatic brain injury, which increases their likelihood of ongoing symptoms and potential post-concussive syndrome. And with that, I just want to say thank you, and we will open up the chat room for questions. One message already. Hello, good subject. Cool.
All right. Thank you again, Stephanie. Just to make it easier, if you guys have any questions for Stephanie, your last name has a lot to say.
Yeah, that's what I said. Stephanie works.
Please feel free to chime in now with any questions. I appreciate everybody's time attending. I know it's a summer. It's hot where many of you are.
Such a talkative group.
They are. They're listening quietly and. No question.
Got lots of hellos, so hello everyone.
Yes. All right. No questions. I'll give you one more. There's a question coming in, I think.
Okay. And if you think of anything afterwards, you're more than welcome to reach out to me. It's that ridiculous long name, Stephanie.Kolakowsky-Hayner at mountsinai.org.
I'll paste it into the chat room here for everybody.
Sure. Do you want me to type it?
I could probably quicker for me to paste it in, huh?
Okay.
I got it right here.
Could you repeat the exercises that we can do in this situation? Actually, one of the best things to do is hop on a treadmill. We have found Dr. Letty out of, I want to say Seattle, but I could be lying. No. He's in Buffalo, New York. See, I was lying. He does a lot of work in post-concussion exercise, and he has developed some really phenomenal treatment strategies to get people's heart rate up and into an aerobic state as soon as possible after their mild traumatic brain injuries, and they have seen significant reductions in symptoms, recovery time, all of that. It's Leddy, Leddy. I don't know why I'm blanking on his first name, but if just Google him. He does phenomenal work, and he's out of Buffalo. He's actually, he's definitely published on a lot of the stuff that he's already doing. I've seen him give a number of presentations as well, but he specifically encourages early aerobic activity. So whether it's walking, just as long as you're, jumping jacks, get your heart yoga, getting your heart rate up, but not overdoing it either.
Very good. Any more questions?
Why do you think the PCS affect more to women than men? Post-concussion syndrome occurs more in women. Again, I think they are more likely to report their symptoms. I think, and research has shown that women are more likely to have symptoms last longer and occur more severely than men. But again, I think it has to do with the likelihood of reporting. You see the warrior or the extreme sport type men who aren't going to report. We see a lot of men who have concussions immediately not reporting because they want to return to play, they want to return to duty, they want to get back and do whatever caused the concussion to begin with. And women are more likely to feel, or more likely to report and obtain treatment than men are. And that's not just with concussion, that's with a lot of different types of issues, comorbid conditions, general health behavior as well. Women are more likely to go to a PCP, they're more likely to get wellness checkups, they're more likely to do healthy visits than men, all of that. It's not just concussion. But again, I think the different studies have shown that women's necks are less strong than men's as well. So you're seeing a little bit more diffuse axonal injury as well.
There's another question coming in from Mo.
It's true. Thanks a lot.
Well, why these last any as this here we go, one more.
So when any insult to the brain occurs, there's chemicals released within the brain, and some of those chemicals impact brain functioning, and so that can lead to neurodegeneration. It's the neurochemical cascade. I'm trying to think of a physician who has published on this. I'm blanking on the name. If I remember, I'll put it in the chat. Well, I'm sure I'll remember as soon as we hang up, but Google neurochemical cascade, and there's articles specifically that explain, after an insult to the brain, how that works. We were on a board together. I can't believe I'm blanking. It's terrible.
All right. Well,
thank you, everybody. I appreciate it. If anything comes up, like I said, feel free to reach out. I'm here.
Yeah, I think we have a shy audience today. So yeah, I'm gonna put my email in here as well. So yeah, any questions you guys have, you can write me or you can write Stephanie, and we're happy to get back to you as best we can. I want to thank Stephanie, Dr. Kolakowsky-Hayner here again for her time, and I appreciate the presentation. I appreciate you guys all being here on a hot summer night. And NeuronUP Academy will be back in September. We're going to take August off, and we're still finalizing, working on the dates and the speakers for that month. But keep an eye on our different social media, and we'll be putting that out there in the future.
Great.
So, thank you again, everybody, and have a wonderful evening.
You too. Thanks, Brian.
Bye.
Thanks, everybody. Bye.